Good morning, everybody. Thank you for tuning in this morning for another MD Monthly live stream segment. Just if it's your first time, what we do is we engage with the audience, the general public, future patients, with our Ask the Expert physicians. Today, this morning, we have Dr. Owusu. Correct me if I'm saying your name correctly.
Owusu.
Owusu. That's a. Let me ask you, Owusu. Well, where's that origin from?
That's West African, from Ghana to be specific.
All right. How long you were born and raised here?
I was born actually in Ghana, and I came to the States when I was 7.
7 years old. Where were you raised at?
Spent a short time in Oklahoma, and then a majority of my youth was in New Jersey.
Awesome. Well, today we're going to be talking about your expertise, which would be back pain, neck pain, spine surgery, and minimum invasive. I mean, what else do you cover under the umbrella of your clinic?
A lot, pretty much the whole gamut, from neck to mid-back to lower back.
Perfect.
And I mean, that's vast, but majority of what I'll be, I guess, discussing is whatever the public wants to know. But in general, talk a little bit about minimal invasive surgery, talk a little bit about motion sparing alternative surgeries to lumbar pain, cervical pain, and what have you.
Well, let me ask you a couple of questions too, as well, that are commonly asked, and I wrote them down already too, as far as your practice. Where are you located at? Are you here in San Antonio, anywhere else?
I am. The main clinic is in San Antonio, right in the Chavano Park area, off of Northwest Military Boulevard, Highway rather. And then I have a satellite clinic in Houston as well, in the medical center in Houston.
Great. And, well, gosh, you're pretty busy. You're traveling back and forth. That's not a bad drive, though.
No, it's become therapeutic. It's a 3-hour drive. It's usually, without any issues, except for last week when we had the Hurricane Harvey. That was pretty tough.
Definitely. And our prayers go out to everybody who are suffering through Hurricane Harvey, and we wish everybody the best. We know our neighborly cities are helping out and doing the best they possibly can. So, and anybody who's volunteered, thank you so much for that as well too. I just want to put that out there. With Dr. Owusu, you may have seen him before. We've done videography on him. We had a mixer with him as well too. If you go to his page, you can see different opportunities to review exactly who he is and what he's doing as far as being one of our experts. He was also showcased a couple of months ago on our cover too. So I'm honored that we can grace his presence, especially providing the substance that we always look for at MD Monthly to be informative as possible for patient care, preventive health care, and anything that's going to be found within this region of South Texas. But one of the questions I want to ask you, and we have 3 topics I want to talk to you about. One is going to be minimally invasive surgery. That term, I hear it a lot, and a lot of people. What exactly is minimally invasive surgery?
Sure. So minimal invasive, although there's a lot of buzz about it now, has actually been around for a long time. And it's not specific to just spine surgery. In fact, our general surgery counterparts have been doing it for quite some time. I'm sure you've heard of laparoscopic, cholecystectomy, appendectomy. Those are all considered minimal invasive. And the notion behind that is that you make a very small incision. You're using a smaller corridor as a surgeon to pretty much do whatever you have to do. And in spine surgery, to be specific, usually it's 0.5 centimeter to 1.5 centimeter incision. And the thought is that you're sparing the muscles and you're sparing the soft tissues and you're not doing as much damage. The hopes is that it will lead to quicker recovery, less blood loss, and usually that is achieved. However, there are certain pathology that minimal invasive just does not work for. And so one must be very careful when seeking a minimal invasive surgeon. Be open to the traditional open surgery, because not every pathology can be addressed in a minimal invasive manner.
And what's the protocol when it comes to that? If someone needs to be referred to you, can they actually come themselves, self-referral? How does that work out?
Absolutely. There are many ways. You can walk in. The clinic is open pretty much 5 days a week, Monday through Friday from 8:30 to 5 p.m. But I take referrals. We have a website that we receive patients from. You can call in and set up an appointment. Whatever is convenient for you, we try to accommodate patients as much as possible. And oftentimes you can be seen within a week or two.
Another topic I want to talk to you about was, and I've never heard this particular term before, motion sparing surgery or sparring surgery. Tell me a little bit about that.
So in the past, spine surgery has been riddled with, especially fusion, with the fact that you lose motion in that segment. And oftentimes that is the case. But now, over the years, we've developed alternative surgeries that address the same pathology, or some of the same pathologies that a fusion would, however, without actually fusing or immobilizing that segment. And so one of those is arthroplasty. So for the cervical, the neck, as well as the lumbar, the lower back, you can do arthroplasty, which is similar to a total knee arthroplasty or a hip arthroplasty, that would enable you to maintain motion while addressing the pain associated with that segment that in the past you would have to obtain fusion for.
Well, let me ask you something. The people who come in, as far as what is it car accidents? Is this maybe they lifted something the wrong way? Is it an injury from the football days? I mean, what typically are you seeing?
Sure, all the above. And it can be somebody just walking, slipping and falling. It can be an athlete that played high school football that has this gnawing pain that just kind of never went away, continues to return and exacerbated by certain motions. And so there's different reasons to see a spine surgeon. But, back pain is one of the most common causes of visits to a doctor. Anywhere from $50 to $60 billion are spent annually for back pain. So it's very common, and there's so many different reasons.
Well, there's a need and the demand there, hence why there's experts like yourself covering that demand and filling that space. At 43 years old, and when my early 20s, obviously I felt invincible and did whatever I wanted to, but the recovery time, just waking out of bed sometimes.
It's not the same.
And I remember back in the day, whether I was in a car wreck or playing out in the beach, volleyball, whatever the case was, and it's just, you feel it, it creeps up on you.
You do, and the best way to kind of remedy that is to stay flexible, keep your joints flexible, keep your back, your knees, your hips all kind of play together, and especially the lower back, you have to keep it flexible. Make sure you're stretching, make sure you're doing the necessary stretches before and after working out. Once your capsules around your facet joints, which are joints, little joints in your back, once they tighten up, it's harder to become flexible, and you're more prone to injuries once you try to do something that you haven't done in a while, like beach volleyball that you used to 20 years ago.
Like Top Gun Tom Cruise.
Yes. I wouldn't recommend it unless you've stretched immensely.
That's just in my head. I thought I'd just throw it out there. But preventive-wise, obviously stretching, maybe yoga. What else do you?
Pilates is another really good workout. So yoga and Pilates are usually what I tell my patients. Extremely important. If you're able to, I highly recommend doing those modalities.
As far as go back to minimal invasive, what should a potential patient? What is it they're feeling? What should they know to say, maybe that's what I need? Is there certain type of, is there signs that they need to come and see?
Sure. So anytime you have pain in general, we don't expect you to come in and tell us exactly what we need to do for you as a spine surgeon. But any type of pain in the neck, the mid-back, the lower back, that radiates down an arm, radiates down a leg, even if it doesn't, if it's across the neck or across the back in axial form, all those can be addressed with minimal invasive. The only situation, or one of the few situations where minimal invasive is probably not the best answer, is when you have instability. And so when you have instability and you stick to the minimal invasive mantra, you may find yourself in trouble, because that may cause more destabilization and make matters worse. In those situations, you want to make either a midline incision to really address the instability, correct it, enable bone placement in the lateral gutters over the transverse processes to facilitate fusion and prevent it from slipping and causing translational instability.
You know, as far as your expertise and your years in practice now, can you tell me a little bit about any success stories, maybe testimonials that you've seen a patient from one point of their stage to where maybe 6, 8 months, 10 months from now,
Sure.
the success of them? Give me a story about that.
So, in general, I like to follow all of my patients for a lifetime. If you have surgery with me, I'll see you very frequently the first year, and then after that annually. And I have patients that I've seen since I first came to San Antonio here 3 years ago. And now it's more like a social visit. They come, we chat about their social life. And that's good. That's a success story. I mean, when we can move on from your spine pathology and now talk about how your cat or your dog is doing, then we've done the right thing. Spine surgery in general has an overall success rate that has been improving. The literature has caught up to it somewhat, but I mean there are incidents of risks that are as low as 50%, or success rates as low as 50%. But then there are some now that are as high as 98, 99% for certain procedures. And so minimal invasive surgery, motion sparing surgery, just the technology has advanced in such a way that it's improving. The outcomes are much better. There are shorter stays in the hospital, you know, while we encourage patients to stay in the hospital for 2 to 3 weeks years ago, or I should say decades ago. Now, oftentimes my patients after multi-level fusion are leaving the hospital in 2 days.
Wow.
Yeah, they're up and walking that same evening, and they're leaving the hospital walking to the car within 2 days.
You know, I think the morning is when people actually feel most, their body's at rest, and then you wake up in the morning, whether it's ankles, knees, back, or neck, whatever the case is. It's definitely something that our body it's an alarm system. It's a defense mechanism as far as, correct me if I'm wrong, that's letting us know, hey, this needs attention to. Is there certain signs that where there's numbness in the leg? Does numbness in the leg also contribute to the back as well? I mean,
sure. So it's the other way around. Usually, it's back pathology can cause symptoms in the leg, and then neck pathology can cause symptoms in the arms. You know, morning stiffness, finding it harder to get up and go in the morning, all comes back to flexibility and stretching. You know, as you sleep, all your capsules contract in your joints, be it your ankles, your knees, your hips, your spine. And so it's important to stretch those capsules and loosen up the muscles around those joints. And as you do that during the day, that's why you're able to maneuver a lot easier as the day goes by.
Your body gets warmed up.
Exactly. But, you know, regarding when to see a spine surgeon, you know, when you have back pain, just back pain in general over the years, the spine surgeons have been taught not to treat back pain just for axial back pain, because there are many different causes of those, and that one of those is psychological. And It doesn't matter how many surgeries you have, if it's psychological, it cannot be addressed. In fact, some research has found that, you know, with degenerative disc disease as a cause of back pain, if you take 20-year-old to 39-year-olds, 39% of them will have degenerative disc disease, which if you see it radiographically, you would think that's the cause of the back pain. From 40 to 60, about 55% of patients will have degenerative back pain and they'll have degenerative disc but have absolutely no back pain.
Does any of it come from a downline of family, like genetic? Or?
There is some genetic component to it, but my point is that you know, you cannot treat radiographic signs of degenerative disc disease. However, there are modalities that you can implant to figure out if that dark disc is in fact the source of the back pain, and it's not psychological or some other modality. And once you really vet it out, once you really address that, and you find that, okay, this is the cause, then there are many treatment options to address that back pain.
Yeah. And I enjoy the fact that you are obviously a scientist behind and do the research and discover, almost investigate the whole, map the body to find out what the issues are, opposed to just generalizing it.
Absolutely.
Because not everybody needs surgery, so there's different levels of what you need to consult them with, correct?
Yeah, outcomes would be a lot worse if we cut every time a patient came complaining of pain. And you do. I mean, as a physician, you have to be an investigator. You have to do the due diligence. You have to go through the differential diagnosis, and you have to find the best one. I mean, you can do the most perfect technical surgery, and if you address the wrong pathology, well, the patient is going to continue to complain, and radiographically you may look awesome, but your work is going to be, non-beneficial to the patient.
Latest technology as far as, is there new equipment out there, new devices, and what's complementing y'all's profession now? As far as you say decades ago till now, less scarring, faster healing, and what else is complementing the
Yes, the beauty of spine is an evolving practice. There are lots of techniques and instruments that have made the work of spine a lot more efficient. And one of those is pretty much every instrument around the minimal invasive spine, which allows a smaller window to work with, less blood loss, and as we said, quicker recovery. All those things have kind of helped in progressing the field of spine. And there's plenty of research in the pipeline, lots of new things coming every day, essentially. FDA has been good at keeping track and kind of keeping it in control here in the United States. In Europe, there's less restrictions. There are a lot more. For example, the motion-sparing arthroplasties. Here for the lumbar spine, there are two main FDA-approved components, but in Europe, there's a number of them. And not to say that, not to say anything negative about Europe, but it's just that the FDA here has regulated too, and I'm sure there's some components in Europe that are just as good. Regarding the cervical spine, there's a little bit more options as far as arthroplastic components that you can use to address neck pain, radicular pain.
How far, the traveling patient is very common due to social media, internet, Google, whatever the case is. Patients or the general public, or they're doing research online, back pain San Antonio, my neck hurts, or whatever the case is. So the traveling patient comes in from out of town as well, correct?
Absolutely.
How far of a distance do you feel that your patients come see you?
Yeah, I've had patients come from Denton. I've had patients come from Corpus. I've had Houston patients see me here and vice versa. And so patients are willing to travel as long as they have that relationship and that rapport with the surgeon. Traveling is usually not an issue, and rightfully so. Even myself, when I'm a patient, I do my due diligence, I do my research, I try to find the best fit, and then at that point, distance is not really an issue.
Yeah. So even though we're here in San Antonio, don't feel that any physician is reachable as far as where you're going to go, because again, your body's your temple. You want to make sure you take care of it the best way possible. We like to utilize our experts to let you know that the option is there, whether you need to travel, and they'll accommodate too as well as far as where you're coming from too. I have a question here online from Dorian Green, and he's asking what age range of patients do you typically see, and then the second question that he's asking, when does back pain start to arise?
Sure. I typically see skeletally mature patients, which can be from 14 to 16 and above. And back pain can start earlier than even 14. Spine surgeons, we do surgery on patients as young as 10, 11, 12 years old, whether it's for scoliosis or certain pathologies. Disc herniations can happen anytime. And so there's never really a good or standard age where back pain starts. The common age is anywhere from 40 and up, but it depends. If you're talking about herniated disc, it's around 20 to 40 years old, but if you're talking about degenerative disc, then it's greater than 40 years old.
Yeah, that 40 is a magic number, isn't it?
It is.
Mayweather was a little bit slower now, but now he's 40.
He went the whole, he used a different technique. He wore his opponent out first before he started striking.
Yeah, exactly. I have another question from Jody. First of all, Dorian, thank you so much for your question and engaging with us. We really appreciate that. We have Jody Marmol. What options do you have for severe neck pain and back pain? Do I have to have surgery? Where do I draw the line?
So, no, you don't have to have surgery. No surgeon will ever tell you that you have to have surgery. There are very rare instances where surgery becomes urgent or emergent in spine. And oftentimes, even then, it's not, you have to have surgery right now type of situation. It's usually, let's try this, let's try conservative treatment, i.e. anti-inflammatories, injections, activity modifications, before moving on to surgery. And once you get to the point where surgery is needed, there are tons, and I mean literally, there are lots of options, because you can approach the neck through, the front, through the back. Once you get to the spine, there's, decompression, there's arthroplasty that I mentioned earlier, there's fusion, so there's many options. And in the back, you can approach it through the front, the side, obliquely, through the back, which is the traditional technique. Once you get to the spine, you can put a graft in between the vertebrae, you can put screws in, you can put the arthroplasty in, you can just decompress, which means remove bone, remove soft tissue to take the pressure off the nerve roots. So there are many options, and so the best thing is to see your spine surgeon, have that discussion, try the conservative treatment, try the modalities, and if surgery is an option, have them describe all the different options that you have to facilitate people.
Again, I'll go back to the protocol just so the general public can understand. If they already have an MRI already, then they come see you. Do they need does insurance matter as far as different insurances? Do they need a referral? How does that work?
Sure. So different insurances do require a referral from your primary care doctor, but in general, I accept pretty much every insurance.
Good.
And so walk-in is usually not a problem. We're able to call the insurance company and do the necessary steps to get you seen. So that's not a problem.
Another question came in from Jordan Davis. Thank you, Jordan, for asking. Jody, thank you, Jody, for asking that question as well. Thank you for tuning in. Jordan Davis, do you think the lower back pain should be primarily rehabilitated with physical therapy first?
I think so. Like I mentioned earlier, there are very rare instances where you have to jump to surgery. And oftentimes 99% of back pain can be at least tried with conservative treatment, activity modification, physical therapy prior to having surgery. And in fact, I'll have the patient start with anti-inflammatories, start with physical therapy. If the pathology continues, then I may send them for injections. And if that still doesn't happen, we have a period of rest in between all of these things, and then if it becomes necessary, then surgery is the last option.
Thank you, Jordan. I hope we answered your question.
Thank you, Jordan.
If you have additional questions, continue asking. We're here to answer anything. Even after the segment is over, the video stream is going to be recorded to where continue asking. Dr. Owusu will go ahead and throughout the week answer any questions y'all may have, and we'll also place his phone number on the comment list to call directly if you need to set up an appointment too as well. We have Van. How's it going, Van? He's asking.
Hello, Van.
Thanks for tuning in, buddy. He's asking, which hospitals do most of your patients recover post-op?
So I have privileges at pretty much every quadrant of San Antonio. So I do a lot of my procedures at the Christus Santa Rosa system, the Baptist system, Southwest General, and so pretty much everywhere in San Antonio. In Houston, Houston Hospital for Special Surgeries is the main one that I do my procedures at.
Awesome. Is there certain days that you're in Houston, or do you commit to certain days over there?
Sure. Usually Mondays and Fridays I'm in Houston. Tuesday, Wednesdays, and Thursdays I'm in San Antonio.
Okay, great. Again, guys, thank you for all the questions you've been asking, and thank you for following MD Monthly. And I want to thank Dr. Owusu as far as giving me his busy schedule to fit in within this time. Is there anything you want to say as far as your website location, what phone number, anything that, and we'll place it as well too on the screen. Any closing statements that you want to advise our general public?
Sure. So we can be reached pretty easily via internet at www.nxgosi.com. We can be reached via phone. We have two numbers: 210-251-2010. Or 210-763-7149. And whether you're in Houston or San Antonio, you can call those numbers and we can direct you to the appropriate facility.
And they're right here. They're pretty much in the center of San Antonio, Northwest Military, Chavano Park area. So it works out for everybody's convenience as far as distance is concerned. But at the same time, he's seeing patients from out of town too as well. So if you're in pain, you definitely want to see someone that's going to be taking care of you and recovery time. And again, it takes homework for the patient as well too, to do their own thing once they come see you, and once whether it's minimal or surgery, to make sure that the recovery time is going to be there. Correct?
Absolutely, absolutely. I appreciate patients that come in with questions already and are really as interested. Or should be more interested in their recovery than the surgeon. But I engage in question and answer sessions with them. Even if they have no questions, I kind of pose situations for them. I go through pretty much my speech that usually incites questions, and so I can get patients to engage that way.
And one of the things I like about Next Generation and Dr. Owusu is that the sincerity and the passion behind it. Again, he makes himself accessible. Obviously, his phone's ringing. It's probably a patient, but that's our also signal to go ahead and tune out. But I want to thank you for following us on MD Monthly. Continue every week. We're going to have a different expert on, and I want to thank you. And thank you for engaging. If I'm looking at my phone, I'm not texting my girlfriend or anything. I'm actually answering the questions. So thank you so much, guys, for tuning in. I hope everybody has a great morning. Stay safe. Do the precaution stretches and everything else that he advised as well too. If you feel that you need to come see him, give him a call. I appreciate your time.
Thank you, Elliot. Thank you, MD Butley.
All right, man.